Despite your best efforts, some patients will go into cardiac arrest. Sudden cardiac arrest may occur in otherwise healthy individuals who can be revived with prompt intervention. Sudden cardiac death occurs when those interventions are not successful. Typically, though, cardiac arrest is due to acquired structural disease like coronary artery disease, cardiomyopathies, or congenital or inherited disease. Often the problem may be electrical, including those with prolonged QT syndromes, either from channelopathies or acquired from drug use, medications, or electrolyte imbalances. Rarely, sudden death may occur due to massive pulmonary embolism, aortic dissection, or stroke. Regardless of cause, sudden cardiac arrest may result in shockable rhythms discussed in the previous chapters, or in non-shockable rhythms. The most common of these non-shockable rhythms is asystole, which is the lack of ventricular contraction. There is no perfusion during asystole, resulting in death. The only treatment for asystole is high-quality CPR and epinephrine. It will also benefit the patient to treat any known underlying causes. The provider should recall the H's and T's, which may include hypovolemia, hypoxemia, hydrogen ion elevation or acidemia, hypo or hyperkalemia, and hypothermia, as well as toxins, tamponade, tension pneumothorax, and thrombosis of the coronary artery or pulmonary vessels. Asystole is associated with a high mortality rate. Another common rhythm is pulseless electrical activity, or PEA. This refers to situations where the ECG or monitor strip shows electrical activity, but the patient has no verifiable pulse. There is no cardiac output despite electrical activity. PEA requires the same treatment as asystole and often degrades into asystole. To treat asystole or PEA, identify cardiac arrest and begin using the primary survey. Check for pulse and breathing, and if absent, begin CPR. Attach defibrillator pads as soon as possible, even if the patient presents an asystole. The rhythm may change during arrest treatment, resulting in a shockable rhythm. Perform high-quality CPR by pushing hard, compressing the chest at least 2 centimeters, and fast at 100 to 120 beats per minute. Allow complete chest recoil between compressions. Remember, the heart feeds itself during recoil. Minimize interruptions and perform 2 breaths every 30 compressions until an advanced airway is in place. Then perform 1 breath every 6 seconds. Use capnography if available. You should establish an IV or IO and administer 1 milligram of 1 to 10,000 epinephrine IV push as soon as possible. This dose may be repeated every 3 to 5 minutes. Perform a rhythm check every 2 minutes, which is about 5 cycles of chest compressions and breaths. Determine the heart rhythm and switch to alternative algorithms if shockable rhythms are detected. Another deadly arrhythmia includes ventricular tachycardia without a pulse. This rhythm is shockable but requires immediate treatment with CPR. Defibrillate as soon as possible using 200 to 360 joules for biphasic defibrillators and 360 joules for monophasic. You may also administer amiodarone. The first dose for patients in VTAC without a pulse is 300 milligrams. The second dose is 150 milligrams. Preference should be given to defibrillation prior to drug administration when limited providers are available. When amiodarone is unavailable, lidocaine may be used as an alternative. The first dose of lidocaine is 1 to 1.5 milligrams per kilogram. Perform a pulse check every 2 minutes and shock is necessary. Continuously follow the algorithm until the return of spontaneous circulation, known as ROSC, is achieved, or there is an agreement to cease efforts. For patients who do achieve ROSC, post-resuscitation care should begin immediately. Targeted temperature management or therapeutic hypothermia may help the brain recover from oxygen deprivation. Targeted temperature management is considered after ROSC if the patient does not regain consciousness. During this intervention, the patient's body temperature is brought down between 32 and 34 degrees Celsius, which equates to 89.6 and 96.8 degrees Fahrenheit. This is achieved using cooling devices for at least 12 to 24 hours after resuscitation. You should also consider PCI and other therapies as determined by the H's and T's. Continue capnography monitoring and monitor glucose levels. Hypoglycemia has been associated with poor outcomes. Not every patient in cardiac arrest will achieve ROSC. Despite the best efforts of rescuers, some medical events will result in death. Continue CPR efforts until there is reasonable certainty the patient will not survive, as determined by field and hospital protocols and patient condition. Remember to treat the patient and not the monitor, assessing for pulse and signs of ROSC. Follow the algorithms and consult expert medical providers as soon as possible. In every cardiac arrest, high-quality CPR gives the patient the best chance for ROSC and should be the initial treatment immediately after discovery.